Hi, my name is Erica Spatz, and I am joined by Dr. Alex Chang, Dr. Kelsey Bryant, and Dr. Arunashis Sau. And we just came out of a terrific session on hypertension management and treatment and the role of AI, artificial intelligence. I wanted to talk to our experts here today because we had a discussion about AI and its role in the guidelines. And then we had a debate for AI and then some of the caveats to using AI. One of the themes that you discussed, Alex, in your talk was around the challenges around workforce limitations as they relate to achieving the goals set forth in our new high blood pressure guidelines, and really kind of teased us with where AI may have more of a role. Could you give us some examples of some of the things that you're keeping your eye on in the AI world around diagnosis and management, particularly around the challenges that we have with access to care and workforce limitations?
Yeah, absolutely. So the need is immense. I mean, there's so many patients with hypertension. When you think globally, there's also this healthcare worker crisis, right? Where there's an estimated 11 million healthcare workers that we need by 2030 to fill that gap. And obesity prevalence continues to rise. Middle and lower income countries are dealing with the after effects of that with hypertension. So there must be some other way to do things that kind of alters the paradigm. And I think, maybe there are some answers that artificial intelligence could help with this. Some of the themes that our great debaters talked about, related to how do we diagnose hypertension and measure blood pressure? Are we ready yet to accept some pulseless devices, which seem promising, but still require a lot of extra validation and work? I think, some of the treatment algorithms are very complicated, but maybe the initial hypertension management isn't super complicated. Maybe some of that could be administered at a larger scale using some of these new AI tools that we have. So I think those are a couple of themes, and I'll let our other panelists talk here.
Aaron, what are you excited about in the AI world around increasing diagnosis of high blood pressure? We have both finding new people with high blood pressure, particularly in places, low and middle income countries where we may not have extensive health systems, but also in really understanding what is people's blood pressure. Are they under good control? What are the new technologies that you're excited about?
Yeah, thank you. So I think that obviously blood pressure, bad cough is the gold standard and will be. But there are novel AI-driven technologies, particularly applied to ECGs, that can detect people that may be at risk of hypertension in the future or already have hypertension that's not yet detected. Potentially has a lot of potential on a population scale. We've also seen studies like the Notify LVH study that looked at identifying people who have left ventricular hypertrophy on an echo, but for whatever reason have not been treated with antihypertensives. And results from that show that we can then start more treatment for people who do have high blood pressure that for whatever reason just hasn't been picked up, even though they've gone as far as having an echo. The cuffless devices additionally has another role, which we talked about briefly in the debate, but potentially, as Dr. Chang said, needs more validation. But there's lots of work here, including potentially large language models and EHR-based models that can identify people who need to just have their blood pressure checked and then have treatment started.
And Aaron, do you see a lot of these tools being deployed in our offices and healthcare systems through doctors and nurses and pharmacists? Or are you seeing these more as being direct-to-consumer devices?
Yes, it's a really good question. So I think that there's really both markets are important. So I think there's a lot of decision support as well as reducing administrative burden for physicians and healthcare providers. So helping for risk stratification, for detection, for potentially simplifying treatment algorithms, and maybe particularly documenting patient encounters in a more clinical setting. In the direct-to-consumer, I think there's a lot of potential in the wearable space. So maybe not diagnosing hypertension, but identifying someone who might be at risk of hypertension that should then be seen by a doctor. And also in recent work with large language models has shown that they can potentially be used for coaching. So can they be used to improve fitness, improve sleep, these things that we know can be useful lifestyle changes to reduce the risk of hypertension or even reduce it when it has manifest.
Kelsey, you brought forward a bunch of examples of how doctors are using ChatGPT or open evidence to find answers to their questions and some of the caveats there. What are you most concerned about in your day-to-day practice? You attend on service with lots of residents. What are the things that keep you up at night?
AI has a ton of potential, but in the examples that I shared today, I think it misses the mark in what we're trying to do. So some of the examples for the audience that I shared were clinical scenarios asking for specific advice on how to titrate medications, how to add another medication, where someone might not have the expertise. And, here at this conference, I'm speaking to a room full of experts. So most people probably have something in their back pocket, but we're trying to develop systems that everyone can use that can improve things at the population level. And the answers I got just weren't great. I was interested to see that the audience thought that one of my responses was AI, and the AI response was actually what I would consider not that good. So I'm concerned about how these tools are actually helping the people on the ground doing the work, actually prescribing and implementing these drugs. So you brought up a point where, you can identify who the highest risk individuals are and make sure that those individuals see a doctor, get started on treatment. So that's me. I'm the one that's seeing them starting treatment, but there's so many barriers to making that happen and getting insurance coverage, all of this stuff. And I think that landscape is different in different parts of the world, but the data digestion itself isn't quite enough until we can act.
I was neither pro or con. I would say I'm somewhere in the middle. And I think the complicated patients, there's always going to be a role for the physician and our advanced practice practitioners or specialists. But like certain cases, I think there's a big potential role. I mean, you have patients where, you see the doctor and you say, okay, I'm going to work on my lifestyle. The doctor doesn't realize that you've been having the same conversation for 1 or 2 years and your blood pressure is high and you should be on medications. So if you could imagine a scenario where you're feeding that information, the patient's feeding that information to some AI chatbot agent, and it's telling them the obvious thing that, look, you should probably be on medication, or have you checked your blood pressure at home? Here's a list of devices. So I think there's a lot of opportunities that we need to tap into, but there's going to be a mix of still having good old-fashioned medicine. And I agree with you with the medical students. I tell them not to read open evidence or anything, because otherwise I'm afraid they're just not going to learn the bright way. But at the same time, I'm still looking things up that way myself. So it's a tricky balance.
And Erin, you mentioned how AI is being used in the radiology world to enhance imaging detection. And we've seen our colleagues really benefit from AI assist, whether it's to triage high-risk CAT scans for PE, bring their attention to something. It does seem like there is a role for this joint clinician, person, human, and then the AI tools. Are there some models within hypertension care that you know of that might represent some of how we might be creative in bringing those two together?
Yeah, I think one potential area is probably secondary hypertension. So we might send people for imaging or lab results, and many times these can be quite complex, MRIs, etc. And at least in our part of the world, in the UK and Europe, there really is a real backlog sometimes in that world, and reporting these scans can take weeks, sometimes even longer. And in a very benign application of AI is simply, as you said, to triage the ones that are likely to be abnormal. If you pick up a scan and someone's got a pheochromocytoma, you want that to be reported soon, and then that can be reviewed by a radiologist and fed back to the physician. So I think that's one potential example where, or in patients with really bad left ventricular hypertrophy or an echo or an ECG, for example. So I think that the triage mechanism is a really benign way and probably where we can dip our toes in the water. But it could potentially go further. So I don't think we're there yet, but in assimilating data about a patient, we could potentially identify people who are not being screened for secondary hypertension that should be, younger patients or ones that have had poorly controlled hypertension that maybe we should have identified earlier, for example.
And Kelsey, what do you see for our future in terms of us as a profession leading the way? What kinds of supports do clinicians need to embrace AI in an ethical and high quality way that enhances our care versus undermining it or eroding away at trust or even expertise? Because if everyone's using AI, there's not really an expert in the room anymore.
Right. I think that we need some evidence of validation. So, for example, I think you brought up a point about how you can't always use a one-size-fits-all treatment plan for everyone. And in some ways, that's what a treatment algorithm is, but there's evidence for treatment algorithms. And so I'm sort of struggling with this idea of how do we use a treatment algorithm for initial management, which maybe is a good idea. Maybe that gets people following guidelines with stage 2 hypertension, single pill combination out the gate. But then I struggle with this nuance of individualizing care. And so I haven't yet seen AI be able to do that for me. So I'm hopeful that it can, but I would need to know that it can integrate into the EHR. It can, pick up that hypokalemia that maybe I missed that happened in 2017 or something like that to help me with my individualized decision.
Great.
And I think that brings one really good point is that we need to make sure that it's identifying the relevant things, but also not over-identifying things that are not relevant or things that we know about, because we've really seen alert fatigue being a major problem with some EHR prompting, and we should to make sure we don't make that worse. And I think that's a really important point as well.
Well, I'm excited because I think that you've raised enormous number of questions, both in the development of these algorithms as well as in their implementation. And it seems like our community needs to be leading that research so that these products don't just get adopted and used before we're able to really do that vigorous testing, validation, implementation work to make sure they're enhancing our lives as clinicians, taking some of that workload off, or enhancing the patient's understanding of their condition and ultimately their health outcomes. So lots of work to do. Thank you so much for being a part of this terrific session, and I look forward to seeing your work in the future. Thank you.
Thank you.